Good afternoon, everyone, and welcome to the webinar, Implementing Best Practices and Improving Collaboration for Crisis Care and Suicide Prevention Amongst High-Risk SMVF, sponsored by SAMHSA's service members, veterans, and their families' Technical Assistance Center. My name is Samantha Holcomb, and I will serve as your moderator for this afternoon. I'm a Senior Director of Practice Improvement with the National Council for Behavioral Health. Before we begin, we just want to draw your attention to some important webinar logistics. There are going to be two audio options for today's webinar, phone or computer audio. If you're using your telephone, please make sure to enter your audio PIN into your phone. You may send us questions at any time during the webinar by submitting them through the Q&A option located in the navigation bar. Depending on the question, we may type an answer back to you or save it for the end. We'll answer as many of your questions as time allows. This webinar is being recorded, and an audio version of the entire webinar, as well as a PDF of the presentation slides, will be available on the Webinar Archives page of the National Council website within 48 hours of broadcast, and links will be sent out to participants. Following the webinar, we invite you to please complete a short survey. And now, if you're ready, Cicely, I'll turn it over to you.
Thank you so much, Sam, and welcome everybody. On behalf of our leadership here at SAMHSA, where I serve as the Military and Veteran Affairs Liaison, I just wanted to extend a grateful thanks to all of you for taking time out of your busy schedules to join us for this really critical topic that will be focused on this next hour or so. We're honored to have some amazing federal and state speakers here today, as well as to hear from you, the audience, and the questions that you'll be able to bring to the table. This webinar topic came out of hearing from so many of you working to support our service members, veterans, and their families at the state and local level around a desire to really ensure that our most at-risk veterans and their family members are being served in systems that are really comprehensive and looking towards innovative ways to make sure we don't let anyone slip through the cracks. So on behalf again of both our panelists today and the amazing team at SAMHSA's SMVF TA Center, we're honored to be joining you for this next session, and I'll turn it over to Don Harris, our SMVF TA Center Senior Analyst, who's going to be walking you through as your moderator. Thanks again, and Don, I'll give this to you now.
Thanks so much, Cicely, and good afternoon to everyone who took the time to join. On behalf of SAMHSA and the SMVF TA Center, I'd like to welcome you to today's webinar, focused on implementing best practices and improving collaboration for crisis care and suicide prevention among high-risk SMVF. Once again, I'm Don Harris, a Senior Project Associate with SAMHSA's SMVF TA Center, and I'll be serving as the moderator today. Just a little background on myself. In my role as Senior Project Associate, I help to support the development of the SMVF Crisis Intercept Map for suicide prevention. We'll talk a little bit more about that shortly. And in my current role, I work with interagency teams across the country in support of their strategic planning and implementation of initiatives to strengthen behavioral health systems for SMVF. I served as an NCO in the Marine Corps, and I'm also an OIF veteran. Next slide, please. Before we get started, I'd just like to read this brief disclaimer that the views, opinions, and content expressed in this presentation do not necessarily reflect those of SAMHSA or of the Department of Health and Human Services. Next slide. And just a little background on SAMHSA. Since 2008, through the SMVF TA Center, SAMHSA has been partnering with states and territories to help strengthen the behavioral health systems that serve this population. And this is done through the TA Center and its partnership with a number of states, cities, and counties across the country. SAMHSA leads efforts to ensure substance use and mental health issues among all Americans, including SMVF, are well understood. Next slide. A little about the SMVF TA Center. It's been in existence for a little over a decade, and we focus on 5 key areas, especially strengthening ongoing collaboration between military and civilian stakeholders at the state, city, and county level, providing a mechanism for sharing and connection between different entities across the locations which we serve, and increasing an awareness of the resources and programs that are available across the country for service members, veterans, and their families. We also support coordinated response to the behavioral health needs of SMVF, and we encourage cities, states, and territories to implement promising best and evidence-based practices, some of which we'll discuss throughout this webinar. Next slide. Some of the TA methods, activities that we do host for different teams across the country include policy academies, implementation academies, crisis intercept mapping, webinars such as this, learning communities, on-site and virtual consultation and strategic planning, and resource dissemination related to this particular population and topic. Next slide. The objectives of today's webinar focus on these three areas. Before we leave, we want to ensure that we describe the SMVF intercepts, the crisis intercepts that we'll be talking about very shortly, and how they present opportunities for supporting service members and veterans in terms of different essential areas for suicide prevention across the crisis system. We'll also discuss some best practices, resources, and tools available to the communities across the country. And we want to talk about some of the challenges that relate to addressing this population, especially in this COVID-19 environment. Next slide. Now, just setting the stage a bit, especially in this COVID-19 environment, looking at the environmental risk factors that have struck our crisis and public health systems, there's been an increased risk for the general population, and especially for SMVF. And it's especially important to develop a targeted focus on those best practices to support those at high risk of suicide. So taking a look at what you see on your screen is the SMVF Crisis Intercept Map tool. It's a model for taking a look at where some of the gaps and opportunities may be across your community's crisis system in order to address those and leverage some of the learnings from that to build those cross-agency, cross-entity connections. It's broken down into 4 broad intercepts, looking at them across the top. First contact would be a lot of the individuals that may come in contact, may or may not come in contact with SMVF or those at high risk of suicide across the community, such as primary care providers, homeless shelters, et cetera. Then moving down to Intercept 2, acute care, which is the heart of this map, really focuses on those organizations and agencies that help to treat and stabilize those at risk of suicide, such as mobile crisis, emergency departments, law enforcement, et cetera. And then moving down to Intercept 3, the care transitions intercept. This is really conceptually one that we want to make sure we focused on because it speaks to that high risk post-discharge. So looking at those entities in the community that can help support those at high risk after their discharge, which is still a very critical point, is a critical process. So looking at the best practices that can be implemented there and the connections that can be made across the community at this intercept is key. And then Intercept 4, finally, to wrap it up, is that ongoing treatment and recovery supports. And that includes those entities that really focused on that recovery, building resilience in the community, and connection to those community supports overall. So next slide, please. So we've been participating in this crisis intercept mapping for the past couple of years. Since 2018, 2019, we've worked with 20+ cities or counties across the country, with another few slated to participate in virtual crisis intercept mapping through the rest of this summer into early fall. Next slide. And so as we talk a little bit about the key elements of crisis intercept mapping and what it helps to support, what we have today are 3 subject matter expert presenters that are going to provide different perspectives on their experiences with crisis intercept mapping and some of the essential elements that are involved in mapping itself, especially looking at screening, safety planning, lethal means safety, and providing those supportive contacts. So today our panel includes Dr. Richard McKeon, the branch chief of the Suicide Prevention Branch at SAMHSA Center for Mental Health Services, Misty Leitch, who serves as the interim executive director for the Tennessee Suicide Prevention Network, and also the Zero Suicide Director there as well. And then finally, last but not least, Brent Arnspiger, who serves as a suicide prevention coordinator for Houston's DeBakey VA Medical Center. And so what I would ask is that you just give your full attention to these 3 experts as they provide different perspectives from the national, state, and local level as it relates to crisis care and suicide prevention for this population. So at this point, what I'll do is turn it over to Dr. Richard McKeon. But before I do that, I'd like to give a little bit of his background. Dr. McKeon not only serves as the suicide prevention chief at SAMHSA Center for Mental Health Services, but also works as the co-chair of the Federal Working Group on Suicide Prevention. And in his role, he oversees all suicide branch activities, including Garrett Lee Smith grant programs, the National Suicide Prevention Lifeline, the Suicide Prevention Resource Center, and a number of other programs at the federal level. Dr. McKeon's background includes over a decade of leadership roles in psychiatric emergency services and hospital-based community mental health. And he's received a number of awards from APA and also the American Association of Suicidology. So at this point, I'd like to turn it over to Dr. McKeon. Dr. McKeon, would you like to take it?
Thank you very much, Don. It's a pleasure to be with all of you today. I'm going to be emphasizing the importance of improving collaboration for crisis care and suicide prevention, which is a need really among all Americans, but obviously we are particularly concerned about high-risk service member veterans and their family members. So you can move on to the next slide. Okay, it looked like either I neglected to put or we skipped over the disclaimer, but you already saw Don's disclaimer. Mine reads the same. You know, basically, if there's anything I say that you don't like, blame me, don't blame SAMHSA. So let me make a few overall comments regarding crisis care and suicide prevention. So the issue for us when you look at the community as a whole is that too often crisis and acute care services in a community are fragmented and poorly coordinated. Now let me emphasize that when I'm talking about this, particularly within the context for veterans, I'm not talking about the systems within VA, because VA has a very well-developed system of coordination that can move from somebody calling the Veterans Crisis Line to being connected to a suicide prevention coordinator at a VA medical center. But in many of our communities, those kinds of linkages which are internal to VA don't necessarily exist. And so there's a need more broadly to be able to coordinate and to collaborate among the various aspects of our crisis and acute care, services. So when I'm talking about those services, I'm talking about crisis hotlines, mobile outreach services, as well as the emergency rooms in non-VA facilities that all need to play an important role. And one issue that comes up is that there is too often a diffusion of responsibility when someone's discharged from a service, which is a major barrier. So for example, if somebody leaves an emergency room, typically when the person is discharged from the emergency room, the hope may be they're no longer at risk for suicide, but we know suicide risk continues. But when the person leaves the emergency room, typically the emergency room is no longer responsible for their care. And if the person might have been given a phone number to follow up on, but it would be not uncommon that the resource that they were referred to may not even be aware that that referral was made. And so it can be very easy to fall through the gaps in our systems. Now, at the same time, we know that over the last decade, there have been significant increases in the number of both adults and youths and young adults seen in emergency departments for suicide attempts or suicidal ideation. Those numbers have been steadily rising over time. So because neither an emergency room or even an inpatient care unit, an inpatient psychiatric unit, since neither of those can completely eliminate suicide risk, there needs to be continuing contact throughout entire episodes of care. So this is where the intercept number 3 that Don referred to is particularly important around care transitions, is that the contact with the person who is at risk needs to continue beyond the points that we typically have thought about as being the end of the encounter, such as emergency room discharge or inpatient care. That means that for veterans, there needs to be protocols and pathways to assist veterans seen in community emergency and crisis systems to be connected to care wherever they wish to get that care, whether it's in the VA or in the community. And it's very likely that a higher number of veterans are seen in community emergency rooms for suicide risk than are seen in VA emergency rooms. I often give the example when I worked in community mental health in New Jersey. There are 2 VA hospitals, East Orange and VA, and Lyons VA. Only in East Orange was there a VA emergency room. So only in that county would a veteran being transported by police or ambulance be going to that emergency room. In every other county, they would be going to the local community emergency room, heightening the importance of protocols and pathways to make sure after discharge, those veterans got the care they needed. Next slide. Now there's recent research that has just underscored the importance of our making sure that people get the follow-up care they need and are contacted rapidly after they leave emergency rooms. In an NIMH-funded study that looked at people within the state of California who had been seen for a suicide attempt, suicide mortality was more than 55 times greater for those people than for a matched population. Similarly, for people seen in emergency rooms for suicidal ideation, but not an attempt, suicide mortality over the next 12 months was also greatly elevated, over 30 times higher. Not only that, there were increases in various other kinds of external cause mortality over that 12-month period, particularly accidental overdose deaths. In a further study that has been released that tracked on people seen for non-fatal accidental overdoses in California emergency rooms, those also found significant increases in accidental overdose deaths over the next 12 months, and as well a significant increase in suicide mortality for those who had been originally seen not for a suicide attempt, but for an accidental overdose. And this just underscores the tremendous importance of our being able to do a better job of making sure that when people leave emergency rooms, that there are pathways and protocols and procedures in place to help them get them the care that they need. Next slide. This slide shows, and this is a VA study back almost a decade ago by Valenstein and all, that shows that even when someone leaves an inpatient unit, there is still elevated risk, and that suicide deaths post-hospital discharge are significantly higher than other time periods. Okay, this was a 5-year retrospective study of over 1 million veterans. Recently, a further study was published that Dr. Ira Katz from VA was the lead author on, confirming again the heightened risk post-hospital discharge. So again, this underscores the importance of collaboration and of continued connection with people at risk until we know that they are connected to care, what is sometimes referred to as a safe landing. Next slide. So when we talk about care transitions as being part of the crisis mapping, as being part of a coordinated crisis system, there are very important reasons to be doing this. There is data that has come from the ED SAFE clinical trial funded by NIMH among 8 emergency departments that looked at people seen in emergency rooms and over 1,300 people who screened positive for suicidal ideation received one of 3 interventions: treatment as usual, screening only, or an intervention that included screening, secondary risk assessment, a self-administered safety plan, and 7 follow-up phone calls over the next year. And they found that this led to a reduction in suicide risk behavior by particularly suicide attempts by 20% over the next 12 months. Next slide. Now, there are some noteworthy developments in crisis services that have tried to move in this direction. I mentioned the ED SAFE study. VA also did a similar very important study called SafeVet. And what the VA found was that the combination of safety planning in VA emergency rooms and telephonic follow-up also led both to a reduction in suicide attempts and to an increase in linkages to behavioral health care. And VA is now implementing nationally what they call the SPED program, Safety Planning and Emergency Department, across VA emergency departments. Part of what we're trying to do is to promote the same high level of care that's now beginning in VA emergency rooms across the country in all emergency rooms. There have also been major redesigns in crisis services that have taken place in states like Georgia, Arizona, and Colorado. There have been improvements in crisis services that have taken place because of Department of Justice Olmstead settlements in states like Louisiana and West Virginia that have incorporated crisis services. SAMHSA has issued significantly more certified community behavioral health clinic grants, and these all have heightened requirements around crisis services and care coordination. And SAMHSA has also issued crisis center follow-up expansion grants that focus explicitly on providing follow-up when people leave emergency rooms, mobile outreach visits, crisis stabilization units. And SAMHSA recently released several more of these grants. Next slide. SAMHSA has also recently published national guidelines for behavioral health crisis care. This is available on the SAMHSA website. The goal is to aim towards an integrated crisis system with no wrong door. The idea here is that three components: a regional call center as the hub of an integrated system that is what we call air traffic control, capable of central coordination, using technology for real-time care coordination while providing high-touch support, while meeting all of the standards of the National Suicide Prevention Lifeline. Next slide. Oh, thank you. Same slide, different bullet points. Also, the availability of centrally deployed mobile crisis services on a 24/7 basis, and residential crisis stabilization programs. So in doing crisis mapping, these are some of the things that you like communities to be able to look at. Do you have them? Do you have parts of it? Some of the places that have done crisis mapping have used that to advocate for additional services that they may be currently missing. Next slide. So when talked about air traffic control type coordination, what does that mean? Well, when we travel back, when we were all traveling much more frequently on the airplanes, one of the things that has helped to dramatically reduce accidents on our nation's aircrafts has been the use of data for continuous quality improvement. And part of that is that at no time, if I'm flying from Washington, D.C. to Los Angeles, at no time during that flight would that airplane not be under the guise or the supervision of an air traffic controller. And when passing from one area to another, care would always be taken to pass along that aircraft. So that's the level of coordination that has helped save lives. It's what we were aiming for in crisis care. Next slide. This is based on what's called the Crisis Now model. And again, the idea of a call center hub, mobile crisis and crisis facilities, such as crisis stabilization unit, other crisis residential facilities, as being core components of a comprehensive crisis system. Now, most communities don't have this. So in crisis mapping, we should identify what they have, what they need, and how to coordinate among the pieces that they do have. Certainly, virtually all communities have access to an emergency room in a local hospital. Next slide. So I'm not going to go into great detail. Don has already shared with you the Crisis Intercept Map that we've been using. Next slide. And this talks about some of the sites. This is where this was used for mayor's challenges and separate crisis intercept mapping sites. My slide is not as updated as Don was, so his has the more recent crisis intercept mapping sites that we've utilized. Next slide. And so one aspect of the crisis mapping is looking at what services do you have, what do you not have, what do you need, how do you work together collaboratively, but then also what is happening within those services and systems. Is there screening? We do know that universal screening in emergency departments doubles the identification of people who are thinking about suicide. Also, does screening ask about history in the services? Do we know that somebody's a veteran? So those are two different aspects of screening. The safety planning, we now have the data from SafeVet, from ED-Safe, and from other studies that are showing the importance of crisis planning or safety planning as an intervention. Certainly one critical component of this is lethal means safety, since most providers don't screen for lethal means in the home among patients at risk. And then follow-up contacts after discharge. Next slide. This is an important study that shows that a part of Intercept 2, which is safety plan and access to lethal means is that this is not asked about routinely, even among high suicide risk emergency department patients. So this is really important for us to be asking on a more routine basis, particularly when we know somebody's at high risk for suicide. Next slide. I'm not going to go into detail. This was the Crisis Intercept Map that Don already showed you. But in the interest of time and getting to our other fantastic speakers, you can just move on to the next. Okay, so I'm getting close to the end. This slide basically makes the point that data and technology is changing nearly every industry in the United States, okay? And so this is a time where any of us can track a package being delivered halfway around the world. So it should not be acceptable for our veterans who are at risk to fall through the cracks of our fragmented crisis systems. And so that is part of the importance of collaboration and of having systems that are working together to make sure that, that the gaps between our systems can be bridged with continuing contact and that the gaps are not lethal. Next slide. Okay, and then I'm going to end that some of you may be aware of this, that SAMHSA, the VA, and the FCC have been working first on the National Suicide Hotline Improvement Act. The FCC is currently working on a final rule to designate the number 988 as a national suicide prevention number. Next slide. And we are hoping that as this moves forward, just as 911 was the linchpin of a transformation in national emergency medical services across the country, we are hopeful that 988 can play a similar role over time to improving and enhancing mental health crisis services across the country. I believe that's my next slide. Let's go to the next one. Indeed. So thank you very much. I will turn it to Don.
Thank you so much, Dr. McKeon. We appreciate that broad overview of the essential elements, the research supporting those elements and what's going into crisis care across the country, along with some of those key initiatives that are taking place. And our next presenter will likely speak to how that research, how that knowledge gets tied into and put into practice on the ground level, so at a state level. So our next presenter I'd like to introduce is, again, Misty Leish. Misty Leish serves as the interim executive director for the TSPN. In this role, she oversees the statewide implementation of the Zero Suicide Initiative by TSPN, along with the other strategies that the TSPN is looking to implement across Tennessee. She also works on the Clarksville, Tennessee Mayor's Challenge team, and also works as a certified trainer for QPR, Assist, Safe Talk, Youth Mental Health First Aid, ACE Safety Planning, and the Columbia Scale across her state. She's a psychological autopsy investigator. And in her past, she's also been selected, had a governor appointment actually as a statewide, on a statewide task force focused on SMVF and the TSPN Advisory Council. So at this stage, I'd like to turn it over to Misty to give us a taste of Tennessee.
Thank you, Don. Hi, everyone. So I want to kind of give you a picture or a taste of what we have in Tennessee and what we've been able to accomplish up to this point, because I do feel that Tennessee is a bit of a unique state, and therefore I do want to share the background with you to better illustrate how and what we are doing in Tennessee with the Crisis Intercept Map. Next slide. Thank you. So we are a partnership of public and private entities. We do receive federal and state funding as well as some foundational dollars. And our primary focus is more education, advocacy, and outreach. So we provide a lot of free trainings thanks to federal, state, and foundation dollars. And so none of our participants are ever charged for a free training in curriculum such as QPR, Safe Talk, Assist, etc. In 2019, we did experience a tremendous amount of growth. We received new state recurring dollars that allowed us to essentially triple our staff. So we went from a size of approximately 4 people, maybe 5 people, to 12 people, which now allows us to embed more within our state and how we're divided up into the different regions. We also have various task forces that are developed as people within the public-private partnership express a need and want to focus on a particular population. So for right now, we have a couple different task forces. We have a higher education suicide prevention task force, a statewide veterans suicide prevention task force, a farmers suicide prevention task force. We just started a first responders suicide prevention task force, and we also have a gun safety task force. In addition to all of those, one city in our state, Clarksville, Montgomery County, accepted the mayor's challenge a few years ago. And so I had the privilege of serving on that task force with some very incredible people. And we have done a lot of great things, and we still continue to meet. More recently, our governor accepted the governor's challenge. And so we have formed our governor's challenge task force, and we are in the early stages of developing that and starting to walk through the Crisis Intercept Map. Also in our state, we have the Zero Suicide Initiative, which is where I started my career with the Tennessee Suicide Prevention Network. I was hired with federal dollars to provide technical assistance and market the Zero Suicide Initiative within our state. And currently we have approximately 33 entities within our state that are implementing the Zero Suicide Initiative. And so if we can have the next slide, please. Those entities are comprised of for-profit, nonprofit. We have A&D treatment facilities, mental health. We have one entity that is a for-profit that provides mental health services to jails and prisons across the country. We have community mental health centers. We have emergency departments. So we have a wide array of companies within our state who are passionate about suicide prevention. So part of my job is to provide each and every one of those entities technical assistance around the implementation of the initiative. I also happen to serve on both the mayor's and the governor's challenge. That has been, in my opinion, one of the best experiences. And with the knowledge that I have of the Zero Suicide Initiative, I'm able to share all of those best practices within the governor's challenge and the mayor's challenge team. And it's been, what I'm seeing is really the interlacing of the Zero Suicide Initiative and the Crisis Intercept Mapping. And it has been a beautiful process to witness. What's happening is our communities are becoming suicide safer. Next slide. So what I'd like to do is spend just a moment illustrating the interlace between the Zero Suicide Initiative and the Governor's Challenge priority. So one of the dimensions of the Zero Suicide Initiative is identify. And what we're trying to accomplish is accurately identifying and assessing individuals at risk for suicide. We promote the use of the Columbia Suicide Severity Rating Scale. We work tirelessly across the state to ensure that as many entities as possible are using the same instruments to screen and assess patients for suicide risk. And what that does is it allows all of us to be speaking the same language. In Tennessee, we have a mobile crisis system that is funded by our Department of Mental Health and Substance Abuse Services. All of the mental health agencies that are contracted through our state to provide mobile crisis services are required to use the Columbia during their screening process. Emergency departments are starting to adopt the Columbia as well. So we're seeing really great progress with that. And again, you see how this ties in very nicely to the governor's challenge in identifying the SMVF population who might be at risk for suicide. Now, during our process of going through the steps in the crisis intercept mapping, that truly gave our team the opportunity to realize or identify where we could be doing better. And by identifying where we could be asking the question, have you served? And so because of that, what we're trying to do in our state is change the culture from asking, are you a veteran, to have you served? And again, we're intertwining the Zero Suicide Initiative with the Crisis Intercept Map by using the best practices, for example, the Columbia, that are built into the Zero Suicide Initiative. And we're more adequately screening for suicide risk and allowing us to help the person in need and get them the help much faster. Next slide, please. And so another dimension of the Zero Suicide Initiative is engage, and it is all about how do we engage patients at risk for suicide in a care plan. This is really important. In Tennessee, excuse me, we not only look at how do we engage the patients that are at risk, but how do we identify and engage the support people around and in the life of that person at risk. First of all, we know that support people can change depending on various factors. They can change very frequently. And so we want to make sure that we're staying up to date in knowing who is identified as a support person for this individual at risk, and bring them in so that they become engaged in the care of this individual. And you see how that, again, ties into the governor's challenge. Next slide. When we talk about safety planning, again, going back to our mobile crisis providers, they are all required to use the Stanley Brown safety plan template, whereby allowing us, again, to be speaking the same language. And we provide trainings on how to conduct an effective safety plan. We do not believe that it is another piece of paper that should just be handed out to an individual. We really believe that it can be used as a clinical tool in the right hands. And again, you see how that overlays with the governor's challenge and the priority about increasing lethal means safety, as well as safety planning. And so just with the process of working on the Crisis Intercept Map, it provided a space for shared learning across our state to understand what entities were using what tools and how they were using these tools to reduce lethal means and increase safety for individuals at risk. And I meant to say this on the previous slide, so I apologize, but engaging individuals in care, especially in the veteran culture and in the veteran world, we want to think about family members. I know this might be a very simple statement, but the SMVF, service members, veterans, and their families. Oftentimes, what I see in our state is families aren't brought into the level of intervention that they could be. And so we're working very hard to not only bring them in, but educate them, empower them, and equip them to help save their loved one's life. Okay, so if we could have the next slide, please. Okay, transition. So again, another dimension of the Zero Suicide Initiative, and we're thinking about best practices within transition, developing MOUs between organizations. One of the great things about the Governor's Challenge and the Crisis Intercept Mapping is we're able to really identify where gaps in care are, and we have the organizations at the table who have the passion and the dedication and the ability to develop MOUs between sectors, between agencies, so that we can get the care for the individual. And we've seen that work quite nicely. So we're really excited about that. Next slide, please. Okay, well, there we go. Thank you. So a couple of the resources that we have in Tennessee, we do have a keyword partnership with the crisis text line, and you see it on the slides. And we also have, again, mobile crisis for youth and adults. We have a new hotline that is for mental health professionals and first responders that is now staffed by peers, so that during COVID-19, during everything that's going on in our world, we wanted to be able to offer resources to our first responders and mental health professionals that would be effective. We have a lot of community mental health centers, crisis stabilization units. We have crisis walk-in centers across the state. In addition to the National Suicide Prevention Lifeline, we also have a statewide crisis hotline. So really pulling in together all of these entities has been phenomenal, because there is someone from each one of these areas in both the mayor's and the governor's challenge. I hope this has been helpful, and that concludes, and I will turn it back over to you, Don.
Thanks so much, Misty. Great information. Thank you for filling us in about some of the initiatives that you're leading in Tennessee. Our next presenter is Brent Arnspiger. Brent Arnspiger has worked at the VA for nearly 2 decades as a clinical social worker, with just about 12 of those years spent as a suicide prevention coordinator. Again, he works at the DeBakey VA Medical Center in Houston, Texas. And in this role, he assists with all aspects of the implementation of suicide prevention initiatives and strategies for that VA Medical Center. He has a specialized training in psychological autopsies, and additionally, he also serves as a clinical instructor at Baylor College of Medicine in Houston. So at this stage, I'll turn it over to you, Brent.
Thank you, Don. Hi, everybody. Again, my name is Brent Arnspiger, Suicide Prevention Coordinator at the VA in Houston. Next slide. So I wanted to cover some brief information about suicide for veterans, some of the risk factors involved there. I'm going to provide a quick overview about the Houston Mayor's Challenge, including how we used our crisis intercept mapping to develop our strategies. I'm going to talk about one of the important strategies we did between the Harris Center and the Houston VA. I'll tell you more about them in just a second. And then how we're going to expand our memorandums of understandings both locally and statewide. And then review the benefits of community coalitions. Next slide. So for veterans, we know that they're at greater risk than the general population because about 18% of the suicides in the United States are in the veteran population, but yet they represent 8.5% of the population of the country. So you can see they're at much higher representation in the number of suicides compared to the number of people there are in the population. So the most recent data that we have shows that there's 20.6 suicides per day, and that includes veterans, active duty service members, Guard members, and reserve. So it's a combination of both people who are currently serving in the military and previously served in the military. About 6 of those 20.6 veterans actually come to the VA for care. So you can see that about 70% of the veterans who die by suicide are not engaged with the VA. So if the VA is going to really have an impact on veteran suicide, we need to get out into the community. And that's where the Mayor's and Governor's Challenges came from. The VA got those going with SAMHSA. Next slide. So there are risk factors for suicide that we're aware of, we've known for quite some time. You can see the list. I'm not going to go over all of those. But the idea is like, how would these different risk factors be impacted when you have a pandemic like COVID-19? So the isolation, employment loss, the stress, you know, all the things that people have to do to try to protect themselves when they go out into public, concerns about getting sick, all of those things will contribute to and impact these other things that are on this list. Next slide. So the Houston Mayor's Challenge began in March of 2018. We have a committee of multiple agencies and different groups, and I'll show you those in just a second. We came up with an overall strategic plan, and we used the CDC's and the Veterans Affairs suicide prevention plans to help us with what we're doing in our action plan. And we used the Crisis Intercept mapping to develop and what we see is out there and what gaps we see that need to be taken care of. So one of the most important questions we want you to ask is, have you ever served in U.S. military? If you ask somebody, are you a veteran, they may self-exclude. Particularly women are likely to do that. Some people think they had to serve in combat or had to go overseas or do different things. So it's much more encompassing if you'll say, have you ever served in the U.S. military? You're much more likely to get a positive response. So we're using the Columbia suicide risk screenings at multiple intercepts throughout our city. The VA has adopted those. We do those screenings in our prime care clinics, emergency rooms, medical units, inpatient psychiatry units, outpatient clinics. It's throughout the entire, even in our sleep lab. So we have different places where people will be doing those screenings. It's particularly important to do those in a prime care area. We know that about a very large number of the people who die by suicide have actually seen a prime care doctor within 30 days of the suicide. So it's very important to get screenings and different things implemented into your prime care non-mental health areas. So one of the most important things that we've done and impactful things that we've done at the Mayor's Challenge is we developed a memorandum of understanding between the VA and the Harris Center. And I believe the next slide I'll go into more of that. We also are doing screenings with our first responders. So the Houston Fire Department has implemented the Columbia screening when they go out into the field. Last I heard, about 50% of the staff had already been trained in that. But we're also working with the Harris County Sheriff's Office, the Houston Police Department, and we're doing different things in those areas for handoffs. So when somebody gets called, they call the police go out, they're going to ask them, you know, have you ever served in the military? Then they can actually call, the police can call us at the VA in Houston, and we can help them with figuring out coordination of care when they come in contact with those people. Same thing with the Sheriff's Office and the Fire Department. Next slide. So these are the people that are on the Mayor's Challenge in Houston. You can see it's, of course, the City of Houston is the lead on that, but the Houston VA, Texas Health and Human Services Commission, which is actually a state-level organization, Houston Police, Houston Fire Department, the Houston Health Department, the Sheriff's Department was recently added about a year ago, the Harris Center, which is our county mental health authority. So the Harris Center provides mental health services. They're funded through the state, but they serve Harris County. And so they actually incorporate more than just Houston. They actually cover more of an area. And they provide outpatient services, and they also coordinate with the different inpatient facilities in the county. So they're a very important provider of mental health services in Houston and Harris County. We also have the Mental Health America of Greater Houston, Combined Arms, which is an organization that helps coordinate services for veterans, Wounded Warrior Project, which is a nonprofit organization that serves veterans throughout the country, and then also the Easter Seals. Next. So for the Crisis Intercept mapping, we actually met in June of 2018 to develop our local map. Each of the agencies identified resources that they provided, and we looked at our local crisis system. We looked at the gaps that were in that system, and then we established different action plans to address the different gaps in the system. And the thing to really pay attention to here is that everything that we have developed in the Houston Mayor's Challenge action plan was done with zero additional funding. So yes, the VA and SAMHSA provided funding for some training, but everything that we've implemented has come with no additional funding. What we've done is We've looked at the resources that each one of our agencies has, and we have looked at ways to better utilize those resources and how to coordinate them to ensure that people are getting assistance. Next slide. So this is our local intercept map. You can see it has the same parts of the map that we've talked about several times already. And you can see the different places that we have intercepts. Now, with the intercept mapping, it says crisis intercept map, but one of the things that's really important is the prevention part. So we really do want to get to people before they're in crisis. We want to get things developed that can help prevent moving into a crisis situation. And that's what we're going to talk about with the memorandum of understanding. So next slide. All right, so in August of 2018, a woman from the Harris Center, Tamara Coy, she came to the meeting for the first time. She worked for the Harris Center and worked in their patient advocacy department. She managed that department. She said, we're going to develop a memorandum of understanding between the VA and the Harris Center, and we're going to do it in 30 days. So we all kind of looked at her like, well, you know, we do work with big bureaucracies. 30 days is a little much. But we did start working on that, and we got that going. It didn't actually happen in 30 days, but we did it in less than 6 months. We did start operating as if we had an MOU before we had the final sign-off, like the formal sign-off for everybody. What the Memorandum of Understanding does is it gives us a warm handoff procedure that we can hand off people between the two agencies. So not everybody who has served in the military is eligible for VA services. So this has allowed us to hand people off as a warm handoff. So like Dr. McKeon said, you know, people are given a phone number. That's what we had to do in the past. We would give somebody a phone number and say, you know, call this agency and see if they can help you. Well, what this has actually allowed us to do is do a warm handoff. So how this works is that when we at the VA, through either our emergency department, our mental health department, our eligibility office, through the suicide prevention coordinators, or different areas in the hospital, when we come in contact with a veteran who is not eligible for VA services, we can call the Harris Center. They have a phone number that we call. We give a warm handoff, a verbal handoff of the person's information, what they're asking for, you know, their address, and all. They have to be in Harris County. If they're not in Harris County, we work with our other mental health providers out in the other counties. So we do get them connected that way. And then we can actually get follow-up from that. So the Harris Center will let us know if they're having problems reaching somebody or that they've engaged them in care. So we know that they've actually been engaged in care. Very critically important. So since we've started this, which was back in October of 2018, we have sent more than 100 referrals over to the Harris Center. And when they've come in contact with veterans, they have contacted us, and we've been able to get 20 veterans sent to the VA through the Harris Center. So one of the really important stories for us is about Tamara's legacy. So Tamara came to our meeting in August, and just a few months later, she passed away suddenly. We didn't know Tamara's motivation for doing this until after she had passed away. And we actually met with a couple of her children after her passing. And we found out that her son was a veteran, or is a veteran, and has had his own struggles. And that's what we learned, is that Tamara's motivation for doing this was to help people like her son. So we've used Tamara's legacy and her determination to get this done as motivation for us to keep this moving and figuring out ways that we can do this in other areas besides just with the Harris Center. Next slide. So this is a graph developed by my coworker Elizabeth. Thank you, Elizabeth. That shows you what we were like before we had the Memorandum of Understanding and what it was like after. So before, if somebody came into contact with the Harris Center, they didn't really have a way to connect them with the VA. They could, you know, tell them to go to the VA, get connected with services. But they didn't know whether somebody might be eligible, different things like that. So with the MOU, the Harris Center can actually call us. They call the suicide prevention coordinators, and we coordinate getting that person into care if they're eligible for VA services. For us, on the other side, for the VA, when somebody would call, like suicide prevention coordinators through our crisis line or different, show up in the emergency room or different places, all we could do was say, here's a phone number, give them a call, see if they can help you. Now we actually, like I said, we actually hand them off. We call that organization, we give them the information, we know they're going to get connected with that. We're not going to just give somebody a phone number and we never know whether they're going to call the number or not. Now we know because we will get follow-up afterwards. Next. So a couple of success stories. These are just two I'm going to highlight. We've had more than this. So on a Friday evening, I'm at home. I got a call from somebody at the Harris Center. They had a veteran who was in crisis. The Harris Center has a mobile crisis team. The crisis team was about to go out with the police department to meet with the veteran to see how they could help him. So I got a call to see if we knew who this guy was and if he was eligible for VA services. So, of course, anybody who's in crisis can come to the VA. You do not have to be eligible for services to come to our emergency room. We'll stabilize you and then treat you and then connect you with care. But this guy, we knew him very well. So I said, well, he's not eligible for VA services. He's never been seen at the VA. But here's the name of his psychiatrist. This is the hospital that he normally goes to. And so they were able to take him to a facility that knew him. So if they hadn't been able to do that, they might have taken him somewhere else, would have been brand new. If he'd come to us, we would have been brand new to us. It would have been like starting from scratch. But we were able to get him connected directly with his psychiatrist and with his hospital. So it was a very nice way to get somebody connected with services, the best services they could get as quickly as possible. So before they even went out to the scene, they knew where they could take the guy. So another story, we had a female veteran. She called the crisis line. At that time, she was not eligible for VA services. So a referral was called over to the Harris Center. They connected with her, got her started in services right away. There was no delay in services. In the meantime, she applied for what's called Service Connection, which is a disability related to military service. She was awarded that disability, and once she had that, she became eligible for VA services. So what they were able to do is that they provided services for her in the meantime. Once she was eligible for VA services, they connected her back with the VA. So there was no delay in care. She was in treatment the entire time, and it started right away. She didn't have to wait for that disability claim to become eligible for VA. Next slide. So what we're doing with our MOU in Houston is we're actually working with other hospital systems throughout Houston. So one of the beautiful things about doing a mayor's challenge is that you have all these different agencies, organizations, and people meeting together on a regular basis, developing the relationships, and figuring out ways to best work with each other. In a place like Houston, it's very large, it's very spread out. All these different entities operate individually, separately. We don't really coordinate very well. So what the Mayor's Challenge has allowed us to do is to sit down and figure out how better we can work with each other. So we're working with our larger hospital systems in the Houston area of how to improve our coordination of care. And we're doing that through expanding our MOUs. At the state level, we're actually looking at expanding these MOUs between all the VAs in Texas. There's 8 major hospitals in Texas with 91 facilities throughout the state, and there's 39 mental health authorities. So we're coordinating with the different VAs and the different mental health authorities and developing MOUs between all of them so that we can spread this throughout the state, so that all the people in the state of Texas will be able to benefit from this, this really incredible intervention that we developed. Next slide. So some of the benefits of having a community coalition, and anybody can do this, to start finding the people that you need to get together in a table, have a place to meet, somebody brings some coffee and donuts, and you got a meeting. So what it's helped us do is develop these close working relationships with these different agencies. And it's not just the relationships that have affected service members and veterans and their families, it's also affecting other people throughout the state. There's different things that we're working on that will actually affect everybody who lives in the city of Houston. So it's spread beyond just the SMVF population. Everything accomplished to date, like I said, was no additional funding. So we didn't get money for staff or any of these different things that we are actually looking at doing, but we didn't need that to get moving. And we now have a community response system. So when somebody is in the field, when there's a first responder in the field, they know who to call. They can connect with the Harris Center. They can connect with the VA. We connect with each other. And then we have other organizations that we can connect with as well. And we look at our system and we continue to analyze it and see, like, how can we improve? What are things that we need to implement in addition to this? And we're actually looking at implementing something with our fire department and our police department that will capture all of the suicide-related calls to 911 in our area, and then how best to work on getting those people connected to services. Unfortunately, we had to put that on hold because we were in the middle of that when COVID came through. So once things clear up a little bit, we're going to get back to working on that. And so because we had this MOU almost 2 years ago now, we actually had something in place so that when something like COVID hit, we had the ability to continue to assist people. The VA is incredibly innovative. We've had the ability to see people on videos for a very long time. We quickly implemented some other things to get more people on, like telephone calls and different things. So when COVID hit, there was no delay in services for people. We were still able to connect with them. They're still able to get their mental health appointments. We just do it through video. The VA had developed an app for your phone several years ago. So we're able to use the technology that we already had in place. So that kind of stuff's very important to develop before you get into a crisis. Next slide. And this is hot off the presses. So this just started on Monday. You're the first group to hear about it. So the VA developed a nationwide deployment, or the nationwide deployment of an emergency care centralized notification system. So when a person goes to an emergency room anywhere in the country, that emergency room or that veteran or the family can call the phone number 1-844-724-7842, and there's a centralized center where they can notify that the person is at the emergency room. They're requesting that you do this within 72 hours of the beginning of treatment. If it's after 72 hours, they still will do their best to assist, but we want to get people to notify the VA within 72 hours. And this will allow coordination of care. It also has the ability for reimbursement to the hospitals, to the emergency rooms, depending on specific things in there. If you want to go to the website for the community care providers, infoemergencycare.ast, they'll have more detailed information about that. But this just started on Monday, and so I'm very excited to announce that and let everybody know about it. And that is my last slide.
Great, thank you so much, Brent. So we're going to move into Q&A now. Thank you everyone so much who's already been engaged and sending in their questions. And if you haven't already, I'm going to encourage you to take some time now to send them by using the Q&A box that should be located on your navigation panel. Cicely and Don, is there anything you want to add before we go into Q&A?
And Cicely.
All right, I'm going to take.
Go ahead, Cicely.
Oops. I'm going to take silence as a no, and I think one of the biggest things that we're seeing right now in terms of questions is related to the crisis intercept mapping. So as a preemptive, we will share a PDF of the document itself because a lot of people had challenges reading that. But we also saw a lot of questions about state level information, either not seeing their states on there, wondering about how they can find more information about their state's work, or how they might be able to get involved. So Don, I'm wondering if you could start us off just by answering some more questions about who people might be able to contact in that regard.
Sure, thanks, Sam. So the crisis intercept mapping, as I said, we've been doing it for a couple of years, and usually the cohorts are a few cities or counties at a time. And during this year, we've had 10 cities or counties participating throughout the summer. For those who are interested, we can be reached. Our email address is SMVF TA Center @prainc.com. And that email address will show up within, if I'm not mistaken, the next two slides, the closing slide as well. But again, that's SMVF TA Center at prainc.com. If someone is interested in crisis intercept mapping for their location.
Great, thank you so much, Don. And I just pulled up that slide just in case, so it's in front of everybody while we're sitting here and going over the Q&A. The next question I have is primarily for Misty and Brent. There are a few questions about how are you measuring impact of these many programs? Are there quality measures or different ways that you're looking at analyzing and collecting data to help you understand the effectiveness?
So that has actually been a big challenge. Sorry, Misty, I'll jump in real quick. So one of the important things to keep in mind is when you start developing these is to do measurements from the beginning. So we've had to go back and capture things that we weren't measuring from the very beginning. But we do have a data person that helps us with our information. We're just starting to analyze some of the data and things that are out there, some of the impacts that we've had. But like even keeping track of how many referrals were made between the agencies. All of those things were important to track from the very beginning.
I would echo that as well. Having your baseline data is extremely important. Otherwise, you can't effectively measure the impact that you've had. We're collecting data from the crisis text line. We just increased our partnership level with the crisis text line so that we now have access to daily information. We also collect data from the National Suicide Prevention Lifeline in terms of all of the calls that are answered, whether it's through our local agencies, how many veteran calls were answered, how many calls were answered outside of our state. We look at our statewide crisis hotline number. In addition to that, to look at the variances in the calls with that, in addition to the number of referrals made for inpatient care, et cetera.
And in terms of measurement, I'd just like to add, especially in Brent's case with Houston, I think Houston was in the first cohort. And over time, this crisis map has taken the learnings from the teams that participated across the country and really evolved from there. So measurement is really built into this crisis mapping process. Like Brent said, you should start from the beginning. That's part of this initiative, is understanding what's to be measured across the essential elements. So if we're looking at, for instance, lethal means safety in a particular setting, understanding, for instance, the % change in the number of providers discussing lethal means safety for those high-risk veterans of discharge. Those numbers can be tracked. And what we're really looking at is tracking those risk factors that we understand are closely tied to the ultimate outcome that we're looking for, is a reduction in suicide. So there is outcome measures and process measures built into this process at this point.
Great, thank you so much. The next question is primarily targeted at Misty. Wondering if you can talk more about the ZSI providers that work with jails and prisons. Do they work closely with the mental health staff in the facilities to help connect individuals and veterans to care upon release?
That's a great question. So the entity that is participating in our Zero Suicide Initiative is actually the contracted mental health provider within the jails and prisons across the country. Does that answer?
Definitely makes, yeah.
Okay.
All right, another question. We have a few questions that are coming in about sharing information on the MOUs. People are looking for similar language. So again, I would just encourage people who are looking for specific information like that, you can email the SMVF TA Center email address and they can connect with you. Another question that we had is, Brent or Misty, could you talk a little bit more about the crisis text line, how the crisis text line Tennessee partnership works?
Absolutely. So we partner with the Crisis Text Line. We've had a partnership with them, what they call a basic partner dashboard, which allowed us monthly access, daily access, but the data was aggregated on a monthly basis. That was a free partnership that we had. And what a partnership means is that you work with the Crisis Text Line to develop a keyword. And for Tennessee, our keyword is the letters TN for Tennessee. So we highly promote, and all across the state, as one of our resources, you can text the letters TN for Tennessee to 741-741. We have partnerships with different entities across the state, and they also promote that. So now that we have a premier partnership with the Crisis Text Line, our data dashboard allows me to look at a plethora of information, including time of day that people are texting in, the number of texters, the number of conversations, what the top issues are that people are texting in, the gender. I can sort it by zip code, by area code, by a variety of metrics that really allows us to identify who is using the crisis text line and then who is not, which gives us direction in where to target our prevention efforts. So the Tennessee Department of Mental Health and Substance Abuse Services, for example, also promotes text TN to 741-741. All of our partners promote it so that we are a unified voice in getting the same message out, whereby allowing us to look at and analyze data from all across the state. And we share that publicly as well.
Great, thank you so much, Misty. Brett, I think this came up in particular to how you engage with the VA and services at Harris Center and just ensuring funding is covered. But do you have any insights on eligibility and how you work with the VA to understand when you're engaging in MOUs, how you're covering the cost of care?
So the Harris Center is funded through the state, and of course the VA is funded federally. We do not give money to the Harris Center for the services they provide. That's through the state. But there are different grants and things out there. I'm not sure of the exact website you could go to, but if you go to va.gov, Gov, there's all kinds of resources on there. On that website as well is a basic, well, I don't know if basic's the right word. There is a short description of eligibility for VA services. It's actually quite complicated. It depends when you served and different things. If you go to va.gov, it'll all explain. But the basic requirement since 1981 is that somebody would have had to serve in the U.S. military for 2 years of active duty. If you served in the National Guard or the reserves only, you would only be eligible for VA services if you were called up to by the president. So like people that have served in Iraq and Afghanistan, many of them were from National Guard and reserves. So if they had that experience, then they would be eligible. Of course, and they would be eligible for the first 5 years. After 5 years of leaving the military, the VA would have to look at your income, and the income is based on where you live. If your income is too high, then you would not be eligible for VA services. So, I mean, it's just very complicated. So do you have a disability from the military? Do you have military sexual trauma? Were you just recently discharged? So there's different eligibilities on there. So that's why I would suggest you go to va.gov. And of course, always call the VA, your local VA, meet with the eligibility office so they can help determine if somebody's eligible or not. You don't want to turn people away if they might be eligible. So I suggest going to the VA and applying for benefits, or you can go to va.gov and apply online.
Great, thank you so much. Now, I think this question was originally intended for Misty when she was talking about safety planning, but I also want to open this up to all of the presenters to think about their thoughts. the question is, do you use no harm contracts as part of your safety planning?
No, we do not use no harm safety contracts. No.
Neither at the VA. In fact, the Stanley and Brown safety planning that Misty mentioned, the VA implemented safety planning using their research many, many years ago. There's no research that shows that no harm contracts actually prevent suicides. So the VA switched to a safety plan, I don't know, 12, 13 years ago. And one part of that is means safety. So something to keep in mind is that over 50% of the people who die by suicide in the United States die using a firearm. And for veterans, that number jumps up to 68%. So lethal means safety is an incredibly important strategy to prevent suicides. Firearms have an 85% fatality rate. So if we can do something to prevent people using a firearm, many times we can impact the situation and save them.
Absolutely, and I'll take it a step further and piggyback off what Brent is saying. The Stanley Brown Safety Plan template, Dr. Gregory Brown and Barbara Stanley recently developed evaluation tools. So there's two separate evaluation tools. One is for the clinician administering and working with the client using the safety framework. And then the other tool is to evaluate the effectiveness of the actual safety plan. So there's another great way to obtain some metrics in addition to that. And I'll say, piggybacking off of the lethal means in Tennessee, 2/3 of our suicides are by firearm. And so we have shifted the way we are addressing lethal means in Tennessee. We are a very red state. We're a very rural state. We have a lot of firearms in our state. And as you all know, this can become a very tricky subject. And so one of the approaches we're taking is, instead of asking to remove the firearm in the home, we're now changing our language to say, let's remove the ammunition from the home. In addition to gun locks and all of the traditional methods of reducing lethal means, but we find that it's less invasive and more agreeable for firearm owners to very quickly get rid of the ammunition in the home rather than the firearm itself.
Also with that, the VA has free gun locks. Veterans can have as many as they'd like. All of your local VAs and clinics will have gun locks. And if they don't have them available at that very moment, they will be able to get them to you. So I would suggest that if you need gun locks, you can go to the VA and they are free.
And I would just add that not only is there not evidence of effectiveness of no suicide contract, there are studies that show negative effects from no suicide contracts. And in many ways, they're really diametrically opposite, in that no suicide contracts are about getting the person interviewed to say what they won't do. Safety planning is about working with the person about what they will do.
Great. Anyone else have any more thoughts on this important topic before we go to what I think will be the last question? Okay. So there's quite a few questions about the new emergency care centralized notification. The first one is just generally, where can we access that announcement to send out to crisis providers and zero suicide partners? Brent, I don't know if you have that information.
It will definitely be on the VA website. I don't know if it's on there today, but it will be included in the slide. And there are links embedded in there, like to be able to get the form. There's a form that you need to complete. But I would first look at the VA website. I'm assuming it would be there as quickly as possible.
Great. And is it possible for you to provide, you might not have this level of detail, but any information on how this information is going to be set up to reach the local VAs? Will the transfer coordinator get a notification, or the suicide prevention team? I think people are just trying to understand the flow of information.
Me too. I just learned about it an hour ago. So from what I was reading, there's a national call center. When somebody calls into the national call center, the local VA will be notified. and then coordination of care will happen through the local VAs. I don't know who the point of contact will be at every VA, because every VA kind of sets things up for what works best for that VA based on the guidelines that they're given. So I don't know if those details have completely been worked out for everybody through all the hospitals, but definitely you want to start calling that the call center because they will be connecting the local VAs, and then that's the way you're going to get coordination of care.
Great. All right, well, Cicely or Don, is there anything you want to add before we close out?
This is Cicely, just to say again, thank you so much. These were really insightful questions that folks brought up, and thank you again to our panel of experts. This was informative and very thought-provoking time spent in the last hour or so, and hope everyone stays well, and we look forward to bringing you more content. So let us know on those evaluations that Sam's about to ask you for what we can do next.
All right, seconded that. Thank you everyone for attending today's webinar. Thank you for our wonderful presenters, and to answer the $100 question that everyone has, yes, you will receive both a copy of the slides and a link to the recording within 48 hours of the webinar. They'll also be posted on the National Council's website for access, and we'll work on getting that PDF to you on the Crisis Intercept mapping as well. And as Cicely said, once you leave today's webinar, you're going to be redirected to a survey on the presentation. We'd really appreciate it if you'd complete that and provide your feedback, and you'll also receive that follow-up webinar or email. So on behalf of the National Council, Policy Research Associates, and SAMHSA's SMVF TA Center, I'd really like to thank you all for joining us today, and please enjoy the rest of your day.